All right, I want to prepare you for your exam on Tuesday afternoon, and we'll be doing the exam at 2 o'clock. And the exam will be covering high frequency ventilation, as well as NAVA, neurally assisted ventilatory assist. Neurally adjusted ventilatory assist. Sorry about that. So what is it that you have to know about all of this stuff? So starting with oscillation. Nothing's typing as I'm typing. So with high frequency ventilation, there's two types of high frequency ventilators that you'll come across. One is the oscillator and the other one is the jet ventilator. So the difference between them, the oscillator delivers breaths up to from 150 up to 900 breaths per minute. It does have an active exhalation, meaning that it pulls the exhaled air back out of the circuit. Jet ventilation is passive exhalation. A special adapter is needed on the endotracheal tube, and that adapter has a port for the bursts or the bursts of the jet to deliver to the airway. So with high frequency ventilation, you're setting a mean airway pressure, and I explained it as inflating a balloon, and then you're pushing and pulling air out of the balloon or out of the lungs in order to ventilate. So oscillations occur above and below the mean airway pressure, and you guys have that in your notes. Showing that the air goes in and comes back out, so above and below the mean airway pressure. We know that as the air oscillates through the conducting airways, the waveform attenuates or diminishes. So it's only like 10% of initial peak pressure or amplitude that actually meets or reaches the alveoli. And neonates much less, like 1% of the amplitude actually reaches the alveoli. And for looking to make sure we're ventilating, we look at the chest wiggling on the infant. We want to see more wiggle on pediatrics and adults, like the upper thigh should be wiggling. And it's that wiggle that tells us that, yes, we are ventilating the lungs. So you need to know how to troubleshoot if you notice that you're not seeing the wiggle. And if you're not seeing the wiggle, then it could mean that there's airway resistance, and it's causing the lungs to not be ventilated as well. So diminished chest wiggle could mean suctioning is needed in the airway. It could mean that the lungs are getting stiffer and they're not being ventilated as well. If the endotracheal tube goes into the right or left main stem bronchus, there will be a diminished chest wiggle because you're only ventilating one side of the thorax. And then for the settings on oscillation, let me. So talking about oscillation or high frequency oscillatory ventilation. What are the settings that we set? So you have to know the settings. And one test question asks you to enter settings for a neonate being placed on the oscillator. So we know that Hertz goes according to body size, and for a neonate, it should be 10 to 15 Hertz. The amplitude for a neonate, you're starting with an amplitude around 16 centimeters of water pressure. So the Hertz gives the size of the tidal volume. Amplitude also determines the size of the tidal volume. So as you're looking at your blood gas and making changes in your CO2, it's going to be Hertz or amplitude. Usually Hertz goes according to body size. So even though if you decrease it, you get a big tidal volume. Increase it, you get a smaller tidal volume. Typically, Hertz stays at the recommended Hertz for that body size. Higher you go with amplitude, the bigger the delta P and the bigger the tidal volume. The lower you go with amplitude, the smaller the tidal volume. So just comparing that to pressure control and setting your inspiratory pressure, it has the same effect. So amplitude is like setting delta P with conventional ventilation. And then for oxygenation, we have mean airway pressure. And we start off with neonates with 8 centimeters water for the mean airway pressure. And of course, you just don't put a number in there. It goes according to your chest x-ray. You want to see the diaphragm at the level of the 9th to 10th rib. That shows that you've got a good mean airway pressure. And if you have too much mean airway pressure, it causes over distension of the lungs, and you actually see the lung tissue bulging between the ribs, or it's called scalloping. So that would tell you you have too much mean airway pressure. So you adjust that according to inflation on the x-ray. And then of course, the other factor for oxygenation is your FiO2. And then with neonates, you typically start with lower FiO2s, maybe 30%. Okay, next we have chest x-ray. We talked about that. To get a good mean airway pressure on an infant, you go according to chest x-ray and rib expansion. On adults, you just look for the degree of opacification to improve. So there is no rib level of the diaphragm with adults. You're just looking for the x-ray to show less opacification. And when mean airway pressure is too much, it also puts pressure on the pulmonary capillaries coming next to the alveolus, and it can actually slow down blood flow it can slow down capillary blood flow going across the alveoli. And what you notice is you have worsening CO2. So if your mean airway pressure gets too high and it starts occluding pulmonary blood flow, you actually see your carbon dioxide levels increasing. You need to know criteria or what are the indications for recommending high frequency ventilation. So the indications, and you have a better list in your notes, but off the top of my head, if the patient is failing conventional ventilation, so they're on high FiO2, high PEEP, and we're still not oxygenating, if we're not ventilating, oxygenation index greater than 19 over 6 hours, then if we have a bronchopleural fistula or a large rupture of the alveoli and air is getting into the pleural space, putting in a chest tube may not be good enough, because most of the tidal volume that we're ventilating with is going out the chest tube and the rest of the lungs are not getting ventilated. Then it's best to switch the patient over to high frequency ventilation. And we watched a video on that with jet ventilation and how much better alveolar ventilation is when you have those small, tiny breaths being delivered to the lungs. So with a pediatric being on the oscillator, if you increase their amplitude and it's not getting rid of CO2, what else can we do to get rid of CO2? So we know it's hertz, we know it's increasing amplitude, but if that's not helping us, do we have another alternative to getting rid of CO2? And the answer is yes, we can deflate the cuff. So you need to review the technique in your notes for deflating the cuff. Because when you take some air out of the cuff and you allow air to leak around the cuff, you'll notice that your mean airway pressure drops. And so you need to have your mean airway pressure to maintain your oxygenation. So what should you do? And the answer is you increase your bias flow until you get your mean airway pressure back to where it was. What are different reasons for a fluctuating mean airway pressure? So if you have a mean airway pressure on an infant of, let's say you're at 12 centimeters of water, and you go in there and you look at the oscillator, now it's down to 10 centimeters of water, then it's up to 15 centimeters of water. Why is the mean airway pressure fluctuating? So you need to know all the reasons why mean airway pressure fluctuates. So having water in the circuit, having secretions in the airway causes mean airway pressure to fluctuate. Any leaks, and am I missing one? I feel like I'm missing another reason why the mean airway pressure fluctuates. So check it in your notes. How do you know when to suction a patient on an oscillator? How do you know a patient on the oscillator needs to be suctioned? And it's one of the reasons why the mean airway pressure fluctuates. Oh, I just remembered another reason for fluctuating mean airway pressure. Probably by now you already looked it up in your notes. But when a patient is waking up from sedation, not necessarily neonates, because they move such little volumes, it really doesn't affect mean airway pressure. But the bigger babies and the pediatrics, when they start waking up from their sedation and they try to breathe, it causes the mean airway pressures to fluctuate. So yeah, that's the one that I was missing. So needing to be suctioned, you'll notice that the mean airway pressure is fluctuating. and your chest wiggle may diminish. All right, now with the jet ventilator, jet ventilator delivers really fast respiratory rates, not as fast as the oscillator. I think we set up to 600 breaths per minute with the jet ventilator. What else do you have to know? You have to know that you need a special adapter on the endotracheal tube in order to deliver the bursts of air or the jets of air. If you're placing a baby with BPD on the jet vent, they do best with a longer eye time. So you're starting vent settings for a jet vent. You have to put that on the exam also. So settings with the jet ventilator, you're setting an amplitude or peak pressure. You're setting a respiratory rate. And you're monitoring servo pressure as one of the different things that you do with a jet vent that you don't do with conventional ventilation, is you monitor servo pressure. And remember that servo pressure increases when the lungs improve. There's one criteria that when servo pressure increases, it's not so great. Having a decrease in servo pressure tells you that you're ventilating less lung surface area, and that can happen when you have like pneumothorax. The lungs are getting stiff, so decreased compliance, increased airway resistance. You'll notice the servo pressure drops. And then another setting for the jet vent is your eye time. So amplitude, like you start with 18 centimeters water pressure. For your rate, you start with a rate of 420 breaths per minute. Your eye time, you start with 0.02 seconds. So not only do you have the jet ventilator, but you also have the conventional ventilator at the bedside. And the conventional ventilator provides FiO2 as well as some SIMV breaths. Now, FiO2, PEEP, and I guess we'll call them, they're called SIMV breaths, so I'll just leave it as SIMV breaths. And the purpose of the SIMV breaths, they act like a sigh. So what are some of the settings that I see? Maybe like 6 times a minute, it'll give a conventional breath. And the purpose of that is to prevent atelectasis. And then you're setting your FiO2 and your PEEP with your conventional ventilator. So there's a saying that you touch the conventional ventilator for oxygenation, that's your FiO2 and PEEP, and you touch the jet vent for ventilation. So if you're needing to change the PaCO2 and the blood gas, then you change your settings on the jet vent. I started talking about settings for BPD, so just to review those. BPD babies need a longer eye time. I think we said 0.036 seconds. They need a lower respiratory rate. So instead of 420 breaths per minute, we use 360 breaths per minute. And avoid giving them sigh breaths with the conventional ventilator, or avoid giving them SIMV breaths. Oh dear. Can't type. There we go. We did it. All right, so that's it for high frequency ventilation. And now for NAVA. So neurally adjusted ventilatory assist. It's a catheter that is put down the esophagus and sits in the stomach, but the catheter has little metal sensors that can pick up the electrical activity of the diaphragm. And then that catheter is attached to the servo ventilator. And when a person inhales, of course, the phrenic nerve sends a signal to the diaphragm to contract. And when the diaphragm contracts, there's an electrical stimulus or electrical impulse that can be detected. So knowing when the diaphragm is contracting helps to synchronize a breath from the ventilator. And then the other thing is when a person has an increased work of breathing, the harder they're working to breathe, the stronger the signal from the brain to the diaphragm. So the microvolts will be much higher when there's an increased work of breathing. If the person doesn't have to work hard at all, there's a lower signal from the diaphragm. So when the EDI signal is between 5 and 15 microvolts, we consider that a normal electrical activity, and it tells us that the work of breathing is normal. When the signal is higher than 15 microvolts, that indicates that the patient has an increased work of breathing. And we would want to help them so they don't fatigue. And how do we help them? So the NAVA adjust allows us to set a level of assist, and it's like a fancy pressure support. So we set this level, the NAVA level, and the NAVA level goes according to the EDI signal. So that's why we have that formula where we're figuring out the total pressure support. It is the EDI signal times the NAVA level. And that'll give us the amount of pressure support. Okay, so let me look at my notes. So I'm giving you the exact formula and just not something off the top of my head. So the exact formula, we take the NAVA level that we have set on the ventilator. We multiply it by the EDI peak, but we make sure to subtract the EDI minimum from that, and then we multiply. So EDI minimum is, there's always some electrical activity of the diaphragm. So even at rest, there's some electrical activity. So we don't want that electrical activity to be triggering unnecessary breaths. So we monitor the EDI minimum, and then we also set a trigger sensitivity of an EDI trigger about 0.5 microvolts higher than that background electrical signal in the diaphragm. So EDI peak, subtract EDI minimum, multiply by the set NAVA level, and that'll tell us how much pressure support. So I think in our notes we had, it gave the PIP, but we would have to add PEEP to that to get the peak pressure. So EDI peak minus EDI minimum times your NAVA so I would need brackets. I'm trying to type this. If you guys are just listening in, I'm trying to type and have it make sense. EDI peak minus minimum times the NAVA level plus PEEP equals PIP. So I think that's what I gave you guys in your notes. So if you have a patient on NAVA and you can use it non-invasively as well as invasively. If you're just using NAVA support and giving the patient pressure support breaths, that's one way of delivering NAVA. Another way is to be monitoring their work of breathing during other modes of ventilation. So you could have a patient in PRVC and have NAVA on the patient, and it would just be monitoring their work of breathing while they're in other modes of ventilation. And what else do you need to tell you? We talked about really high pressures. You'll see neonates on NAVA and you'll see the peak pressure of like 90 centimeters of water. That boggled my mind until I realized that it's mostly airway resistance and that pressure is nowhere close to what's arriving at the alveoli, especially when they have nasal CPAP. So you've got air going into the back of the nose. There's a lot of airway resistance there, getting through the conducting airways. So those high pressures that we see on the neonates are not the pressures that are occurring in the alveoli. All right, so you'll have to fill out the formula to figure out the amount of pressure support. If you have an EDI signal of 0, you have to know why you would have a signal of 0. And if a patient has an EDI signal of 20 microvolts, what could you do to bring the work of breathing down to a more normal level? Hello. Hi. Nope, I'm empty. Thank you. Those are all the questions on NAVA. So I think this will prepare you well for your exam. Make sure you're going through your notes and just brush up on what your notes have to offer. And then also go through this review, and I think you'll be all set for Tuesday. Let me know if you have any questions.